Thank you very much. Salam alaikum. It's a great pleasure to be asked to talk about the transesophageal echo assessment of the aortic valve and surrounding structures. And when I was given this assignment by Dr. Kadura, I thought, well, the brief said surrounding structures as well, and I thought about the use of transesophageal echo in a native valve assessment, prosthetic valve assessment. Dr. Rafai was just mentioning how useful transesophageal echo is in assessing prosthetic valves. We also want to look at subaortic and supraaortic lesions, masses on the aortic valve and outflow tract. We want to look for endocarditis. And the ascending aorta, we're looking for dissection, intramural hematoma, and coronary arteries. I won't say much about dissection, as there's another speaker going to explain that later. So what about native valve assessment, native aortic valve assessment? What's the gold standard for native valve assessment? It's the transthoracic echo. Really, with native aortic valve stenosis and regurgitation, TE is still the gold standard. It allows a comprehensive Doppler assessment. Dr. Ali Shiri showed us some lovely images of how difficult it is to align the CW Doppler to really get a good Doppler tracing during transesophageal echo. So still, transthoracic echo is very, very important. This patient who has severe aortic stenosis with late peaking of the gradient here is 5 meters per second, and also has aortic regurgitation. So the transthoracic echo here is diagnostic. We don't need to go to transesophageal echo. However, transesophageal echo is indicated where the transthoracic echo is inconclusive, or further information will change the clinical management. If there was a question about endocarditis or some other lesion that couldn't be fully elucidated from the transthoracic echo. Transesophageal echo is very useful for assessing morphology of the valve leaflets. When you get images like this, you can clearly see we have a bicuspid valve on the left of your screen and a tricuspid valve on the right of your screen. This is a patient who it wasn't quite clear from the transthoracic echo what the morphology of the valve was. But here we can see that this valve is clearly bileaflet. There's a small eccentric jet of aortic regurgitation. And one very important point here about the aortic valve is it's very important to assess the aortic valve in systole or diastole. Which one do we assess it for? In systole, yes, because here's in systole. You can clearly see that this is a bicuspid valve. This is obviously the very nice 3D image. But when it's in diastole, because of fusion of the raphe, you would say that this is a trileaflet valve. You'd think this is a Mercedes-Benz sign. So that's an important point to be aware of. Remember that bicuspid aortic valve may be associated with disease of the aorta, and the 2014 American College Guidelines suggest replacing the aorta if it's more than 55 in a patient with bicuspid valve, or if it's more than 45 if they're already going to undergo aortic valve replacement. Actual dissection of the aorta is very rare in patients with bicuspid valve, but it still occurs more commonly in the bicuspid population than in the normal population. Coarctation may occur, and bicuspid valve comes in different flavors, if you like. Type 1 is where you've got right and left cusp fusion, and there is some evidence that that may be associated more with regurgitation in adults, whereas type 2, which is the right and non-coronary cusp fusion, may be associated more with stenosis. And this was one of my patients who had a bicuspid valve. You can see a very dilated aortic root, and he underwent concomitant aortic valve root replacement at the time of aortic valve replacement. And what's this? Coarctation. Coarctation may occur in some patients with a bicuspid valve. Okay, now, what's wrong with this valve? This was a young man who presented with severe aortic valve regurgitation. This was a number of years ago in Dhahran, I think 2004. And unfortunately, these are the only images I could find. I couldn't find the Doppler ones because in those days we had them on videotapes. So anyone want to hazard a guess here? Aortic dissection, I hear. Anything else? Subaortic membrane. This is a native aortic valve. This is an unusual one, and it's the only time in my career I've seen this. This was a young man with a quadricuspid aortic valve. It's a 4-leaflet valve. And again, if any of us saw that and we saw severe aortic regurgitation, the first thing we're going to think about would be dissection. It looks a bit like dissection, but when you look at it carefully, he's got 2 very large leaflets that are prolapsing, and associated with this was severe aortic valve regurgitation. He had a successful aortic valve replacement. I do apologize, I couldn't find any of the other images, but it's a very rare thing. Unicuspid aortic valve can occur as well, but this tends to present in the pediatric group with severe valve dysfunction. I've never seen a unicuspid valve in an adult. Maybe some of my colleagues have. I know Dr. Rafai has a collection of weird and wonderful things. One use that transesophageal echo may help us is with the etiology of the aortic regurgitation. This patient has severe aortic valve regurgitation. What's the etiology of this regurgitation? What can we tell from this is again a short axis view, as Dr. Shiri was telling us. We can see very nicely the aortic valve, the intraatrial septum bisects the non-coronary cusp, and then we can see what's happening here in the middle. Non-cooptation, and this is due to what we call annulo-aortic ectasia. The ascending aortic root was dilated, and this stretched the aortic valve, and this patient required replacement of the aortic root. Dr. Rafai very nicely talked about prosthetic valve assessment, and this is really where we do need transesophageal echo. If there's a question of prosthetic valve endocarditis, prosthetic valve malfunction, very often the transthoracic echo may not give us the full information, and this would be certainly a class 1 indication if there is a doubt to perform a transesophageal echo. And we heard that there are many different types of prosthetic valve. What type of valve is this? Yeah, this is a tissue valve. And what type of regurgitation? There's 2 types of regurgitation you can get with a prosthetic valve. You can get it through the valve, or you can get it paravalvular. So the question is, and it's if it's paravalvular, very often that is in a sense more sinister. It can be more sinister. One might be concerned about dehiscence of the valve. So we've got a short axis view of the aorta and a long axis view here, as Dr. Shiri pointed out. Sorry. I'm not sure why. This is a very sensitive mouse here. So this is a patient with a tissue valve, and just to point out what a tissue valve looks like, because they do have these protruding support stents. So you can see very nicely the 3 stents here. This is the left coronary artery, and so that will give you a clue as this is a tissue valve. This is the view that Dr. Shiri was telling us, very difficult to get. Transgastric view is here we had to come around to 63. You should line up at 0 degrees, but very often it is quite difficult, but eventually we are able to see the regurgitant jet. And again, from transesophageal echo, the Doppler will be inverted, so the forward flow is away from the probe, and the regurgitant jet here. of aortic regurgitation. So this patient, I think, had moderate aortic regurgitation. Here's another patient who had a tissue valve and was doing very well, and then came suddenly with pulmonary edema. And all we could hear was a gallop rhythm. Chest X-ray showed pulmonary edema, no fever. What's going on here? What do we see? Again, we've got a short axis view on the left and a long axis view of the aorta, showing quite significant aortic valve regurgitation. The transthoracic echo showed signs of severe aortic regurgitation. And this was a 3D image. Actually, what this patient had was a complete perforation of the one of the leaflets of the aortic valve. Thank you. So again, sometimes when we see dropout, if we actually see a hole on a valve in 3D, sometimes we're wondering, is that something we've created, or is it true? I think those of you who do 3D a lot will realize that, particularly the aortic valve, sometimes when you're making 3D images of the aortic valve, it looks like there's a hole in the valve leaflet, but this was a genuine hole in the valve leaflet. What about mechanical valves? This is a bi-leaflet valve. As Dr. Fay showed very nice images, you can see the sewing ring, make sure the valve is well seated. And one of the most important things about the valve is it opening and closing correctly, because if there's thrombus or pannus, it may not open or close properly, and you need good Doppler assessment. And very often we use a combination of the transthoracic for the Doppler as well as the transesophageal echo to look at valve motion and closure. I tend to also use fluoroscopy or CT if I can't see the leaflet closure, and this is functional CT of a patient with an aortic valve, short axis and long axis. You can see very nicely the movement of the leaflets. This is a 57-year-old gentleman who had a redo aortic valve replacement in 1998. Original aortic valve replacement in 1993 in the context of endocarditis. He received a Smeloff cutter ball and cage valve, and then 6 years later he got a St. Jude bileaflet valve. He had, at the original time of endocarditis, a VSD, and he also had a perforation of the mitral leaflet that required repair. But since 1998, 15 or 16 years ago, he's been doing very, very well. And over the last few months, he's been getting breathless, increasing breathless. And this is the transthoracic echo. Again, on transthoracic echo, if you look at the image on the right, you see this acoustic shadow that plagues the echocardiographer in assessing the valve. No obvious regurgitation on the colored Doppler to suggest a problem with the valve. This is a short axis view of the valve seen on the transesophageal echo. The leaflets, this is just one image, the leaflets appear to be opening and closing quite nicely. And as we rotate around, we could see this. What's going on here? There is an area of lucency here just in the aortic annulus or the aortic ring, and you can see flow going from this area into the left atrium, and this is very high velocity flow. So it's coming from the left ventricular outflow tract. It's reaching 6 meters per second going into the left atrium, and this shows it very nicely. So this is what we call a fistula. Someone said fistula is a connection between two chambers. So this patient has a fistula. So the question is, where is the fistula exactly? And, sorry? Just below the valve, yeah. And we should also rotate the probe around. And when we rotate the probe around, this is what we see. This is the anterior mitral leaflet. And just at the connection between the anterior mitral leaflet and the aortic continuity, this jet is visible. So the jet is actually coming through just below the aortic valve, and the continuity of the aortomitral fibrous continuity. You can see a little whiff of aortic regurgitation, the actual repair of the mitral regurgitation. And you can also see here just what some people call the designer jets. These valves are designed to have little cleaning jets to prevent platelet and fibrin aggregation. So this shows, when you look at both of these images, it's a fistula just below the aortic ring, through the aortic mitral continuity into the left atrium. What about Starr-Edwards valves? Starr-Edwards valves are a silastic ball within a cage. We don't see them that often now, but still we have a lot of patients with the Starr-Edwards valves. This is a patient with a double valve who presented with increasing breathlessness post-operatively. He had both aortic and mitral valves. This is the aortic valve, and the aortic valve appeared to be functioning well, but there is a problem with the mitral valve. What's one? Okay, and this is the problem with the mitral valve. There was a dehiscence between about 9 o'clock and midnight here. This is the fluoroscopy. This is the mitral valve and the aortic valve. And again, I'm not as confident an echocardiographer as some of my colleagues, so I tend to use fluoroscopy as well. But this patient had a valve dehiscence and was successfully reoperated on. What about masses on the aortic valve? This is a patient who is undergoing TEE for assessment of mitral valve disease. And if you look very carefully, there are some little mobile hairs seen on the aortic valve, both in the short axis here and in the long axis. What are these? Lambel's excrescences, yeah. First described in 1856 by Dr. Lambel. These are usually considered benign, but they may be an nidus for platelet and fibrin aggregation. And there are cases of embolic phenomenon. Sometimes they can grow very big. They're usually on the aortic valve, but they have been described on other valves as well. And they're pathologically, they're different to fibroelastomas. They don't have the same smooth muscle cells and rich mucopolysaccharide matrix that you see with fibroelastomas. But Lambel's excrescences, they often cause echocardiographers a lot of concern when you're doing a TE with a patient suspected endocarditis. But they're like little hairs on the valves. This is another patient with a mass on the aortic valve. What do you think this is? Fibroelastoma. You can see this is it's fibroelastoma. These are often described as sea anemone-like, frond-like, and they grow on valves. They tend to embolize. That's the main concern, and this one seems to be on the non-coronary cusp. This is a functional CT scan on the left, because what I tend to do is do non-invasive coronary angiography prior to surgery. And again, you can see the non-coronary, the intraatrial septum bisects the non-coronary cusp, and it will be coming here. So this is on the non-coronary cusp on the TE. Again, papillary fibroelastomas are histologically benign, but they may be malignant because of their position. More common on the aortic and mitral valves than in the other valves. It's a rare lesion, but the second commonest benign heart lesion after myxoma, often present in males and females after the age of 60. And we worry about embolic phenomenon, but they can also cause sudden death due to coronary ostial occlusion. This was a patient presenting with chest pain. He had a previous PCI, and this was his transthoracic echo. Anyone see anything? Nothing much showing on the long axis view here, but there seemed to be something on the aortic valve. So transesophageal echo was advised, and this is the transesophageal echo. So again, a mass on the aortic valve seems to come from the left coronary cusp on this situation. And we felt this was most likely, again, a papillary fibroelastoma. And just to point this out, you can see the association with the left coronary artery, and it looks like that this patient has separate ostia to the circumflex and LAD. And so this patient we know had a previous PCI. So the interventional radiologist or cardiologist a little bit reluctant to stick a catheter there into the left coronary artery. So non-invasive CTA was done, and you can see very nicely separate ostia here to the circumflex and LAD. There's moderate atheroma, no critical disease. And this is the actual filling defect on the contrast-enhanced image. But it shows you how close these things can be to the valve. What about endocarditis? Again, there's guidelines. If there's a strong clinical suspicion of endocarditis, transthoracic echo is performed. But if in patients with prosthetic valve, poor quality transthoracic or positive transthoracic TE is indicated. And again, also if you have a high clinical index of suspicion of endocarditis, and even though your transthoracic echo is negative, you'll still proceed to transesophageal echo, because transesophageal echo has a much higher yield or sensitivity in detecting vegetations than transthoracic, probably in the mid 90% sensitivity versus 70% for transthoracic, or 60 to 70% for transthoracic. And again, just to remind you, the European guidelines say if your initial TE is negative, if you still have a high suspicion of endocarditis, particularly with an organism that's a high predilection to cause endocarditis, like staph, for example, you might want to repeat that transesophageal echo within 7 to 10 days. This is just to show you vegetations on the aortic valve with valvular destruction, and very often what we see is mobile echo densities. They move independently to the valves. There's often associated valvular regurgitation, and these are this is from Feigenbaum, the features of a vegetation: low reflectance, they're attached to valve, usually on the upstream side, irregular shape, amorphous, mobile, oscillating, and you get tissue damage, valvular regurgitation. Negative features would be if they're very hard or calcified, there's a non-valvular location somewhere in the heart, they're smooth or fibrillary, like little fibrillae, like fibers, like lambles, they're non-mobile, and there's no regurgitation. This would be less likely to be valvular lesions, vegetations. And we mentioned fistula. Fistula is a communication between two neighboring cavities, and this is what we see on echo, but also we're looking for other complications of endocarditis, like an abscess, a pseudoaneurysm, a valve aneurysm, a dehiscence of a prosthetic valve. I showed you a dehiscence of a valve earlier. It wasn't in the context of endocarditis. This was a lady who had a recent tissue aortic valve for, I think, bicuspid aortic valve disease, and was doing very well, but then presented with a high fever. Blood culture is negative, and a TE was asked to be done to rule out endocarditis. And there was no obvious vegetations on the valve. I won't show you all the images, but this was the tissue aortic valve. You can see the leaflets are mobile. It's a little bit hard sometimes to image the leaflets. But what's the striking abnormality here? Anyone shout? Striking abnormality? There's an echo-free space here posteriorly in the aortic root between the aorta and the left atrium, and this is due to this. And we can, as we come around to the short axis view, this is the left atrial appendage here, the aortic valve, and you get the impression it might even be rocking a little bit because there's a big abscess here in the aortic root, and this patient had an aortic root abscess and required urgent redo surgery. This is, just a point now. This is a lady who presents with fever, high fever, new murmur of aortic valve regurgitation. Transthoracic echo shows aortic regurgitation. And what do we see on the aortic valve? We see some mobile echo densities on the aortic valve. And this is just an example that not all vegetations are due to endocarditis. This was a patient who had proven giant cell arteritis, a temporal artery biopsy, and this is a positron emission CT PET scan showing intense uptake of FDG PET throughout the aorta. And these vegetations resolve with steroid therapy. So non-infective vegetations, also described in Lehmann-Sachs vegetations, also described in other conditions. Just briefly about subaortic pathology. This was a middle-aged, slightly obese lady who presented with increasing breathlessness, systolic murmur, suspected aortic stenosis. The transthoracic echo shows what looks like aortic stenosis and regurgitation. So was sent for transesophageal echo prior to considering aortic valve replacement. So this is the transesophageal echo. What are we seeing on transesophageal echo? Subaortic membrane. And the subaortic membrane, the patients will often have aortic valve regurgitation because there's a very high velocity jet hitting the underside of the aortic valve. And the aortic valve leaflets don't like that, and they often become regurgitant. And this patient had a subaortic membrane, you can see very nicely here. And that patient had successful resection of that subaortic membrane. This is just some 3D images here showing the membrane. And this is another patient with a subaortic membrane. You can see very nicely on 3D the membrane. What about LVOT pathology? This is a 62-year-old gentleman. He had diabetes, hypertension. He came to us CABG about 10 years ago. He had non-STA segment elevation 2 years earlier. He's got renal impairment, and he's actually doing quite well. He's mild breathlessness, routine checkup, and a transthoracic echo was advised for assessing LV function. Anyone see any abnormality on the echo? There's something in the LVOT. You see here? There's something under the valve here. So what do you think this could be? Vegetation, maybe? What investigation would you do next? That's an easy question. T, okay. So is this a tumor? Is it a vegetation, a thrombus, an artifact, or is it a normal structure anatomic variant? What do you think? I have to ask the experts here. So we did a transesophageal echo, and you can see something bouncing around in the outflow tract. This is about 130, 140 degree mid-esophageal view. You can see the aortic valve opening nicely, but there is definitely something here in the outflow tract. Gain settings aren't so optimal. So what you have to do in a situation like this is take multiple views and then look at them very carefully. And we could see a structure that originates at the base of the aortic leaflet here, and at one end it's a very long structure, and it's also attached to one of the chordae to the anterior mitral leaflet. And this actually prolapses through the aortic valve in systole. This was a rare aberrant chorda. Here's another mass in the LVOT, a 74-year-old history of hypertrophic cardiomyopathy, septal myotomy 14 years ago. And basically he presented what looked like cancer, a lot of anorexia, night sweats, and he was admitted to rule out malignancy. A transthoracic echo was done, and we didn't see any obvious vegetations, but so he was sent for a TEE, and it shows an abnormal aortic valve, something flickering there in the aortic valve. But when we go round to this view that Dr. Shiri was mentioning, the mid-esophageal view here, we could see definitely something in the outflow tract. Just finish up quickly. This was vegetations in the outflow tract at the and culture negative endocarditis, and his symptoms of cancer improved when we treated his endocarditis. Briefly about the ascending aorta. This was a patient who just to present with chest pain, high index of suspicion for dissection. If you look at the time here, this was done literally 5 minutes or 6 minutes before the transesophageal echo. And we looked up and down, we tried to get the probe and point it and see if there's any dissection flap. Just by passing the TE, we could see this obvious dissection flap. Again, don't rely on transthoracic echo for diagnosing aortic dissection. Sometimes you can see it, but if you really suspect it, lazim, you have to do transesophageal echo. I'm not going to talk much about that because one of my colleagues will talk about it. Here's another patient who had an intramural hematoma. An intramural hematoma, you don't see a dissection flap. You just see the hematoma in the wall. And just one or two more. I should finish very briefly. Sometimes you can actually hear on the anterior wall of the aorta, this patient had a penetrating aortic ulcer with an intramural hematoma. And sometimes you can actually see the dissection extending into the coronary artery. So again, just to remind everyone to do a comprehensive TE examination. You may look at one valve, see pathology in another. You may see something like appendage thrombus. So again, I've covered these very briefly in this talk. Thank you very much. Thank you.